Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Lilly.
Hi, I'm Dr. Erica Hamilton, and I'm the director of the Breast Cancer Research Program at Sarah Cannon Research Institute in Nashville, Tennessee. Welcome to this activity entitled Hormone Receptor-Positive, HER2-Negative Early Breast Cancer, the Adjuvant Clinical Trial Populations Explained. Joining me today is Dr. Nadia Harbeck. Nadia, please introduce yourself.
Yeah, it's a pleasure to be here with you, Erica. And I'm Nadia Harbeck. I'm the director of the Breast Center at the LMU University Hospital in Munich, Germany. And I'm a breast medical oncologist, trained gynecologist, actually.
Fantastic. I always love that about Germany. We're going to start by talking about the prognostic implications for patients with early stage hormone receptor positive HER2 negative breast cancer. So first, let's talk about a case. This is a 53-year-old female for my practice. She had a 4.1 centimeter asymmetry seen on a screening mammogram, and this was biopsied. The biopsy revealed a grade 3 invasive ductal carcinoma that was both ER and PR positive, HER2 negative with IHC of 2+, but FISH non-amplified, who had a positive sentinel lymph node. She ends up getting neoadjuvant chemotherapy based on those high-risk characteristics and then goes to have a mastectomy. At the time of mastectomy, she has 4.4 centimeters of residual breast cancer. It remains high grade, grade 3, and unfortunately, she also has 3 out of 6 involved lymph nodes. She does have adjuvant breast radiation and obviously planning endocrine therapy. I think one of the really hard things, at least for patients in my clinic, is to really understand the risk. I think as oncologists, it's hard to expect someone to make a good choice for themselves about what therapies they may want in the adjuvant setting if they ultimately just think that they're cured and don't really understand the risk in the short term or the long term. So I love to use a little person diagram where I kind of draw a box and say there's 100 people in this box, right? Every man here represents somebody with HR positive breast cancer. If we do nothing, meaning nothing besides taking your tumor out, we would estimate your risk of recurrence at being a 40%, meaning that 60 patients are going to be cured regardless of what we do, but 40 are going to have their cancer come back. And this is represented here in the diagram. Then I talk about what we can do to lower that risk further. So for example, with your endocrine therapy, your aromatase inhibitor, this decreases the chance of cancer coming back by 50%. And so now we can think about that 40% risk of recurrence as a 20% risk of recurrence. And then we talk about the chemotherapy. With the chemotherapy you received, this probably decreases your risk another 20 to maybe 30%, depending on the chemotherapy they received. And so now your risk is around 13%, and kind of show them this diagram and keep moving through the people of kind of how their risk is shrinking. And then ultimately in higher risk scenarios like this, we get to CDK4/6 inhibitors where our data is a little bit less mature. And so I typically tell them that there are 2 CDK4/6 inhibitors available. We don't have the full follow-up on these trials yet, but so far we see a benefit that's increasing every year of follow-up. So monarchE has follow-up that extends out past 5 years now. And at 2 years, the benefit was 3%. It widened to 5% at 3 years, and then it widened to 6% at 4 years. And now at 5 years, the benefit is almost 8%. NATALEE, on the other hand, is a little bit newer. We see a very similar pattern of growing benefit year over year. So at year 3, the benefit was 3%. Now at 4 years, it's up to 5%. And so I tell my patient, the question is, are you comfortable with your current risk of relapse? Or would you be interested in taking an additional drug with your endocrine therapy for 2 to 3 years longer if it would decrease the risk that cancer comes back? And depending, when we get into talking about the side effects of that drug, how old my patient is, what their life circumstances in, that really sets the stage pretty well to have an educated conversation and ultimately a decision from them about whether they're interested in that additional risk of recurrence. So, Nadia, with 2 CDK4/6 inhibitors approved in the adjuvant setting, let's take a deeper look into the clinical trials data.
Yeah, I love to do that. I was, as an investigator, involved in both trials and was also part of the executive committee of monarchE. So I've been with these compounds in their early breast cancer evaluation right from the beginning. And I think they're going to make a big impact for our patients as they specifically address the high-risk situations. Let's look at monarchE first. I mean, the patients that were eligible for this trial had either 4+ lymph nodes or 1 to 3 lymph nodes, and then a grade 3 disease or tumor size larger than or equal to 5 centimeters. So really, really high risk selection. And that was over 90% of those patients. And there was a small cohort, 9%, where you could enter with 1 to 3 involved lymph nodes and just a proliferation of Ki67 of 20% or greater. That cohort came a little bit later, so the data is not as mature as for the overall population. And then patients were eligible to get abemaciclib for 2 years together with their endocrine therapy or endocrine therapy alone. And abemaciclib was used at the standard dose, 150 milligrams twice daily, and you have thus 2 dose reduction steps to 150 milligrams twice daily. Abemaciclib in the monarchE study could be combined with AI as well as tamoxifen, which gives us a little bit flexibility with regard to the endocrine backbone. The IDFS benefit was about 8% at 5 years, and the distant relapse-free survival benefit is about 7% at 5 years. And I think this is the more important number, because every patient, unfortunately, who will have a distant relapse will eventually die of the disease. Although, as we're seeing in these trials, patients still have a very good survival probability for a longer period of time in this setting. So the IDFS benefit is visible basically across all subgroups, be it according to grade, according to tumor stage, according to age, so pre or post-menopausal, very consistent benefit. We don't see an overall survival benefit yet. There is a numerical trend with about 25 deaths less in the abemaciclib arm. Hazard ratio is below 1. So there's a trend numerically for better survival in the abemaciclib group, but both arms do extremely well. And I think it's just premature to want to see an overall survival benefit, because we do have good agents in the metastatic setting, and some of these patients actually live for a long time with their disease. If we look at the toxicities, I think we know them from the metastatic setting, and diarrhea certainly is more pronounced than with the other CDK4/6 inhibitors. There's less neutropenia and leukopenia with the abemaciclib than with the other CDK4/6 inhibitors. And if you look at the timing of the adverse events, it's early during the treatment. So I think that shows us that we have to really pay attention to this side effect, try to dose reduce, and give patients the benefit of finding the right dose, and then continuing with the therapy, but also continuing with their lives. And we've done extensive quality of life assessments also in the monarchE study, and actually patients do have a good quality of life in both study arms. So that shows that the treatment really doesn't impact quality of life that much. The other trial, NATALEE, also large phase 3 trial, around 5,000 patients, and it used ribociclib together with an AI plus minus a GnRH, depending on menopausal status. And ribociclib here was used at 400 milligrams per day, which is 1 dose step less than it's approved for in the metastatic setting. And it was given for 3 years in addition to the endocrine therapy. And NATALEE differed slightly with the inclusion criteria. It included all patients with node-positive disease, but it also included patients with node-negative disease if they had high-risk features. And the high-risk features the investigators chose was grade 3 or grade 2, and then an additional high-risk factor like high proliferation, same cutoff as in monarchE, 20%, greater than or equal to 20%, or a high-risk genomic profiling result. And I think that was a very wise decision, because if you look at those patients with high genomic risk, they do poorly in all of the trials, despite having received endocrine and chemotherapy. So I think it's a good selection of high-risk node-negative disease. And we just saw the 4-year data presented by Dr. Fasching at ESMO 2024, and we see about a 5% difference in IDFS at 4 years. So I think the curve's developing in the right direction. We do see a full-fledged carryover effect in the monarchE study, but the follow-up is a bit longer. But here in the 4-year data of NATALEE, we sort of see the curves go apart, and this is the first time that we've seen data with all of the patients already being off treatment. So I think this is a major step forward with regard to the data we have now for NATALEE. If you look there at the IDFS benefits according to subgroups, we see it's basically very similar, also numerically in the different stages, but also in the different nodal subgroups. And again, here the overall survival curves look very, very similar numerically, around 20 less deaths in the ribociclib arm, hazard ratio 0.8. But again, I think we need to be patient here, because these patients do fortunately have a good survival also in the metastatic setting. So with regard to toxicities, we know that ribociclib has a little bit more hematological toxicities. We're used to that. We do have some liver enzyme toxicity, which we have to watch out for in order to then stop the treatment and act accordingly to the level of enzyme toxicity, as well as what's written in the package insert about how to dose reduce, hold the treatment, or even stop permanently. So, and then obviously with regard to management, we have the EKG monitoring during the first a couple of weeks in order to see that there is no QT prolongation, but nothing that we were not used to from the metastatic setting. And if you basically look at NATALEE and monarchE together with the inclusion criteria, we see that all patients, except for the ones with a very low risk disease, like small tumors, node negative, have the chance to get one of these two drugs. And they've been recommended by NCCN with a high level of recommendation, and also by ESMO and all the other relevant international guidelines. I just want to point out that we shouldn't forget in the hormone receptor positive HER2-negative space to think about germline BRCA mutations. We do have the Olympia data. We just saw at San Antonio 2024, the 6-year data with a 4% overall survival benefit at 6 years presented by Dr. Judy Garber. And I think we just need to keep in mind that the Olympia study included these luminal breast cancers if they had 4+ nodes. So there is an overlap with the monarchE and NATALEE study, but also if they had non-PCR and a CPSEG score of 3 and greater. So there is a proportion of patients, although I think if you calculate it, it's probably just 5% or so, where there is an overlap between olaparib and one of the CDK4/6 inhibitors. But I think we tend to forget the testing, and that's why I wanted to emphasize it.
Yeah, absolutely. So let's talk about a separate case. This lady is 54 years old. She is postmenopausal. She also has a screening mammogram that shows a small 6 millimeter asymmetry in the left breast. Ultimately, she is referred for biopsy, and the pathology returns grade 1 invasive ductal carcinoma, ERPR strong positive at 100%, and HER2 negative with an IHC of 0. She undergoes a left breast lumpectomy and a sentinel lymph node biopsy, which reveals 8 millimeters of low-grade invasive ductal carcinoma in the breast, negative margins, and her sentinel lymph node, luckily, is also negative. So she's a PT1B in 0. She does elect for adjuvant radiation therapy, but Nadia, maybe you could start for this case of what systemic therapy would you recommend for this patient and kind of how do you see her risk?
Well, I would say, I mean, she's a typical screening case and rather low risk to begin with. And we would probably just recommend endocrine therapy, AI, or if she doesn't tolerate that, even tamoxifen in such a low risk situation. We would probably not even take her to staging procedures because the risk is so low, and give her the radiation therapy and look at her bone mineral density. And if she has problems, there maybe add a bisphosphonate also for the adjuvant approach, but also to stabilize her bone mineral density. So that's not a case where I would consider CDK4/6 inhibitor. And just maybe a point, because we saw the INSEMA data in San Antonio, that would be probably a patient where we could even forego sentinel lymph node biopsy in the future. And we talked to Dr. Reimer at the German guideline meeting, and he said they're going to publish also some analysis, how many patients would you need to do sentinel nodes in the INSEMA population in order to find one patient for NATALEE. And I think it's over 100 patients. So it's not worth it in the INSEMA population to do sentinel nodes just to find that one patient where you may overlook a ribociclib indication, because they're going to be at the lower end of the risk spectrum anyways.
Yeah, I completely agree with you. I guess under what circumstance, I mean, given that NATALEE does include some patients that are in 0, what are those flags, or what are you thinking about? Who is the no-negative patient that is at higher risk, separate from this case?
Well, I would follow the NATALEE criteria. I think the investigators did really well in selecting those high-risk patients, because the high genomic risk is an unmet medical need in all the trials, be it MINDAC, be it TAILOR-X, be it our Plan B study here in Germany. All those patients with a high genomic risk, even though in those studies they all got chemo and endocrine therapy, they do poorly. And so I think those are the patients where we really need to do something in addition. So those patients for sure. Then I think grade 3, even though it's always disputed how subjective it is and whether you can really use this as a prognostic marker. If you look at the Oxford overview analysis, grade 3 clearly signifies a high risk. So I would follow those criteria, and I really think that they did a good job in selecting the very high risk node negative population. And if you look at the results, the benefit is about 5% at 4 years, just like in the node positive situation. So there is no risk, I think, to no reason to distinguish between node negative and node positive. If they have a NATALEE indication, I would treat them.
Yeah, I completely agree with you. And I really loved those curves from earlier of kind of the node negatives separated out from the node positives in NATALEE, showing that the node negatives got just as much benefit and maybe even numerically a little bit more because they were picked based on other high risk characteristics. So I think that's really important to remember that this isn't everyone with negative nodes. It's really that select group with high risk disease. So let's change the scenario a little bit. Let's make this patient higher risk. So say this patient had a 6 centimeter tumor now instead of an 8 millimeter, is grade 3, and has 2 positive sentinel lymph nodes. I think we'd all agree that this patient is now high risk for a recurrence. How would you be thinking about options for her? And how do you have conversations about the different options at your disposal with a patient?
Yeah, in Germany, we have both of the drugs, ribociclib as well as abemaciclib, available in the early breast cancer setting, and this patient fulfills both criteria. It's NATALEE includes all node positive patients, and the abemaciclib indication is with additional risk factors in those patients, 1 to 3 lymph nodes, and she has 2 lymph nodes, but she has a grade 3 tumor and it's larger than 5 centimeters. So I think she could be a candidate for both. I mean, it'd be interesting to hear how you do things, but we tend to prefer abemaciclib wherever there is a monarchE indication, just because the data is more mature. We see this carryover effect, 8% difference or 7% if you look at distant disease-free survival at 5 years, and it's a 2-year treatment. And I think once you get past this, the first 2 or 3 cycles with the diarrhea and you find the right dose, then I think patients do quite well. And for the minority of patients where you have tolerability problems, I'm glad that we now have a second CDK4/6 inhibitor, so we may want to change the drug. But I would give her abemaciclib for 2 years, and I think she will benefit from it very nicely.
Yeah, I completely agree with you. I too, I think I like to call them the kind of moderate high risk patient and the ultra high risk patient from monarchE. I think for those patients that do qualify for abemaciclib, we have longer follow-up. Yes, the ribociclib curves look similar so far, but I normally would try for abemaciclib there. And there's certainly a much larger population that may be eligible for ribociclib. And I agree with you. It's really nice to have two because they do have different side effect profiles, right? Neutropenia is certainly more common with ribociclib, even though it is at the 400 milligram dose, which is, one dose lower than we have approved in the metastatic setting. We can see QTc alterations with ribociclib. And then when we talk about abemaciclib, although neutropenia is less frequent, we have more diarrhea. And so certain patients, you may tolerate one better than the other, but absolutely correct that these populations don't completely overlap. What do you think about impact on patients' quality of life? When do you think the risk really justifies, not a short intervention? It's not, 4 cycles of chemo, for example. It's really asking a patient to take additional medications for 2 to 3 years. What do we know about quality of life data here?
We looked in depth in the monarchE study. There is already some data out for NATALEE, but since monarchE was reported earlier, there's a bit more data out there. And what we saw was actually that patients do have a good quality of life. It's not different between the 2 study arms, which shows that in principle, this CDK4/6 inhibitor doesn't impact on quality of life. And that's also true from what we've already seen from the NATALEE study. The interesting thing with abemaciclib is that patients are bothered by diarrhea. So I think that also sort of is a good quality control, that it's actually patients report what they're actually feeling, because you would expect that. But that immediately ceases after the study treatment is over, after the 2 years, and they're bothered a little, but the majority of patients can handle it quite well. And there was one other thing that we noticed. If you look at fatigue, you would expect the CDK4/6 inhibitor to cause fatigue. But if you look at the control arm, you see that also in the control arm, there are some patients that are quite fatigued after, the chemotherapy. Majority of all these patients we've just been talking about in NATALEE as well as monarchE had prior chemo and the surgery and the radiotherapy. So I think that is something we have to take into account. And it's not just the CDK4/6 inhibitor, it's fatigue also after the other treatments. And I think we have to make sure that our patients get over that and are able to continue with their life, be it working, be it caring for their family. But I think we have to be aware of that. And that is not just the CDK4/6 inhibitor.
Yeah, I think those are fantastic points. Maybe just also to mention the possibility of dose reductions. Our data from the clinical trials really shows that we're not using those probably as much as we should. The monarchE data at least showed that half of the patients discontinued without trying a dose reduction. And so I find, particularly with the diarrhea from abemaciclib, sometimes just one dose reduction really makes a world of difference for patients. And so I actually cancel my patients up front. If you don't tolerate this well, there's things we can do to make you tolerate better, perhaps a dose reduction. So they kind of mentally don't stop at home, decide they're done with it, come back, and then you kind of introduce the idea of a dose reduction and they're already just moved on. They're not going to take it. So I have been talking to my patients up front about that. Nadia, I want to ask you the hard question. What about a patient that's sufficiently high risk that would qualify for a CDK4/6 inhibitor, but also has a BRCA mutation and would qualify for PARP inhibitor? How do you think about that, and picking one over the other, or how do you handle?
I mean, in Germany, we have a very comfortable situation because we could actually sequence these two modalities. But first of all, it's only about 5% of all the patients. So it's not the majority, but it's probably patients where we consider they have a very high risk. And we also may have some doubts whether CDK4/6 inhibitor actually works so well, because there's some data from the metastatic setting saying that maybe those patients don't derive such a great benefit if they have a BRCA mutation. But we saw data last year at ESMO Breast where Dr. Desmet showed that the abemaciclib benefit is actually independent of the BRCA mutation status. So that gives us confidence that you can also use a CDK4/6 inhibitor. So I personally would start with olaparib for 1 year because it's a completely different treatment modality, has an overall survival benefit. But I would then tell my patient we do have an additional sort of efficacy enhancer for the endocrine therapy that I'd love to offer her afterwards. And then we will see whether she's still up to having more therapy or just wants to stay with the endocrine therapy. But in principle, we could give olaparib for a year and then use abemaciclib or ribociclib. Even in the monarchE study, there were patients that were 1 year out from primary diagnosis because some of the radiotherapy was delayed in some of the countries. Would you do the same or would you handle this differently?
Yeah, I agree with you. I think sometimes it's hard in breast oncology because we don't have randomized data for every scenario. Unfortunately, or fortunately, depending on how we look at it, drug development is pretty fast. So I think that this is a little bit of a data-free zone, but I think for somebody that's really high risk, you do think about offering both of them. So absolutely agree with you there. I've really enjoyed this conversation, really starting from estimating risk and how to explain risk to patients, the different tools we have at disposal, certainly chemotherapy and endocrine therapy, which was not the focus of this discussion, but really both ribociclib and abemaciclib, the differences between these drugs and the populations that may be eligible for additional risk reduction. Really how we talk to the patients about this, explain side effects, and ultimately try to translate more patients to cure. Nadia, thank you so much for this great discussion. Thank you, the listeners, for participating in this activity, and please continue on to answer the questions that follow and complete the evaluation for your credit. Thank you so much.